And want to give a word of thanks again to AstraZeneca and Bristol Myers, along with Pfizer, for supporting us this year. And turn it over to our presenters this morning. I'm going to ask Lauren Baldassarre from Yale to introduce herself and her team. So thanks, Lauren.
Awesome. Thanks, Stephen. Happy New Year, everyone. We're excited to present to you today interesting case conference about a patient on checkpoint inhibitor therapy with sort of unclear, as you'll see, clinical presentation with the sort of complex differential and case management. And we have our awesome fellows today in cardio-oncology and cardiac advanced imaging presenting. First, you'll hear from Jason Cuomo, who will first give the case presentation. He's done a great job taking care of this patient clinically, and we'll kind of give you kind of run through the whole presentation of him up until this point. And then also Jennifer Kwan, our other fellow, who's done a great job of summarizing the literature about this and including sort of up-to-date stuff that's just been published within the last day or week or so. So thanks to both the fellows and their great job taking care of this patient clinically and then also presenting this case. And I'll let them go ahead and get started. Jason will get started.
Thank you, Lauren, and thank you, Stephen, for having us. So we present the case of a 62-year-old male treated for metastatic melanoma with an experimental regimen consisting of ipilimumab, nivolumab, and a CD40 agonist. He has a history of pigmented epithelioid meningeal melanocytoma of the right occipital lobe, which was diagnosed in the late 1990s following appearance of a visual field deficit. The course of that disease was complicated by local recurrence requiring multiple resections, 4 treatments with stereotactic radiosurgery, and whole brain radiation. He was never treated with chemo or immunotherapy, and he has been had been progression-free since 2005. He has no other past medical history. A few words on his neoplasm. Meningeal melanocytoma is a benign and indolent tumor that is histologically similar to meningioma. It may become locally invasive or may transform into malignant melanomas. It is most commonly found in the cervical or thoracic spinal cord or in the posterior fossa, though supratentorial lesions are known to occur. Because it is slow growing, it often presents as a slowly evolving neurologic deficit, as in this case. In April of 2020, our patient experienced abdominal discomfort in the right upper quadrant, for which he underwent CT imaging at an outside facility. The study revealed the presence of multiple lung lesions bilaterally, measuring up to 2.4 centimeters in diameter, as well as 2 hepatic lesions measuring 13 and 5 centimeters, respectively. The liver tumors were biopsied, and the diagnosis of metastatic melanoma was made. The lesion's morphologic characteristics were similar to those of the previously biopsied brain lesions, and newly available immunohistochemistry profiling suggested a primary meningocele as their origin. MRI of the brain was reassuring, displaying leptomeningeal enhancement at the site of previous instrumentation, but no visible tumor and no change since 2015. On the basis of this data, the patient's metastatic melanoma was characterized as slow-growing, well-differentiated, and with a low mutation burden. The high tumor burden was deemed likely the work of years of unsuspected growth. The case was discussed in tumor board, where it was agreed that the patient would be appropriate for enrollment in a phase 1 clinical trial evaluating a regimen consisting of 2 immune checkpoint inhibitors and an experimental CD40 agonist. I won't steal Jennifer's thunder by talking too much about these medicines, but the CD40 agonist, which was the truly experimental drug, triggers an anti-tumor immune response by several pathways, which are well depicted here. First, it binds with high affinity to dendritic cells, monocytes, and B cells, causing them to increase presentation of tumor antigen. Second, it stimulates macrophages to infiltrate and deplete tumor stroma, converting cold tumors into hot tumors. And third, it stimulates production of IL-12 and 15 by APCs. These interleukins activate natural killer cells and augment the cytotoxic immune response. So the patient was monitored closely for adverse effects, of course. During cycle 1, he reported several nights of epigastric discomfort occurring when lying on his side or stomach and relieved by rolling onto his back. The discomfort was associated with dyspnea, but in quality, it was similar to indigestion and was treated as GERD with a proton pump inhibitor by his oncologist with temporary resolution. A month later, however, this discomfort recurred and then worsened, predictably awakening him from sleep at 3 a.m. each night, and otherwise usually occurring when he was at rest. Laboratory evaluation revealed a grade 1 increase in LFTs with AST predominance. This prompted the team to check cardiac biomarkers, and troponin returned elevated at 0.08. The patient was referred urgently for cardiac MRI ahead of cardio-oncologic evaluation the same week. So these are the patient's labs drawn as part of the initial workup of his chest pain. Note the CK elevation and the AST predominant elevation in his LFTs. These are the patient's EKGs before an initiation of immunotherapy and after detection of cardiac biomarkers, both performed while the patient was asymptomatic. They are substantially unchanged, showing LVH pattern and ST segment changes that are slightly accentuated in the latter EKG and not suggestive of ischemia. So a cardiac MRI was performed within a week of the patient's laboratory evaluation, revealing a normal systolic function, elevated T2 signal in the apical anterior LV, mid-myocardial delayed gadolinium enhancement in the infraseptal and inferior segments, and in the pericardial in the pericardium there was delayed enhancement adjacent to the lateral wall. The myocardial findings were more consistent with a non-ischemic pattern of injury. The pericardial findings suggested an etiology for the patient's chest discomfort. And note the T2 color map here showing abnormal elevation of T2 signal in the apical anterior myocardium. And this image shows you the subtle mid-myocardial delayed enhancement and pericardial enhancement occurring in a non-specific but probably non-ischemic pattern. So the next day, the patient was seen in cardio-oncology clinic where he was asymptomatic and appeared well. His vitals were unremarkable. His exam was benign. Troponin was repeated and returned marginally increased from previously. No immunotherapy had been given between biomarker assays. It was felt at this point that though the relationship of his chest discomfort to his biomarker elevation and MRI findings was uncertain, because it was quite sort of atypical and non-specific discomfort, his history was concerning for subclinical immunotherapy-associated mild pericarditis. Moreover, ischemic heart disease still had to be excluded, particularly given the potential for plaque destabilization in patients receiving immune checkpoint inhibitor therapies, and of course, more on that later. All of this was discussed with the patient and his oncologist, who felt that the risk-benefit ratio favored the compromise approach that entailed holding a dose of immunotherapy while deferring immunosuppression pending further evaluation. So a two-pronged approach to that assessment was decided upon. It consisted of expedited outpatient ischemic workup with coronary CTA, as well as close observation for sequelae of ICI-associated mild pericarditis, such as heart failure, and malignant arrhythmia. The latter was to be surveilled with weekly serum biomarkers and home event monitoring, as well as repeat cardiac MRI prior to the next dose of immunotherapy. This information would then inform decision-making regarding continuation of therapy, cessation of therapy, and or the use of immunosuppression, which were really the three options that we had at that point. So this is a good place to pause.
Yeah, I mean, I guess,
discussion.
Stephen, I don't know if we should just keep kind of going through and discuss at the end, or if people want to kind of chime in or discuss what, they think about kind of the management at this time point.
Yeah, totally up to you. It might be helpful to see if there's any questions just about the information presented so far.
Sure. Why don't we see if there's any questions, and we can also like discuss at the end as well.
Lauren, this is Dan. Thanks for preparing this. We've had a number of cases somewhat similar to this, where, if they have some degree of myocarditis, it's low grade and it's going to be hard to figure out. And then when we get an MRI, we have kind of modest findings, just like this one.
Mm-hmm.
And then the question is that if you truly felt that there was myocarditis, it seems as though from recent publications that the timing of high dose steroids is kind of critical. So the earlier that you treat, the better the outcome. Now, that's not a organized or randomized study, but nonetheless, there's some data that suggests early high dose steroids are better than later high dose steroids. And then the other question is how convinced at this point would you feel that there is myopericarditis? Because when I look at those MRI findings, they're pretty subtle.
Yeah, I mean, those are all great points and questions, and I basically 100% agree with everything you said. And, I think one of the reasons I like this case is, and we all who practice cardio-oncology clinically are obviously, in these challenging scenarios in a real world, way. So it's like easy to say, oh, there's myopericarditis, like give steroids and, don't give the therapy. But like in this patient who was like, is like 62, has like literally no other medical conditions, completely functional, doing well. And his main issue is this, new recurrence of metastatic melanoma. And this is his main option. And he's also, by the way, in a clinical trial. So if we treat him then he's going to go, with steroids, he's going to be taken off of that as well. And so there, as Jason mentioned, there were really hours of discussions, with the oncologist, with the patient's family, and ultimately, like with shared decision making, the patient decided that he wanted to take the risk, knowing that this what appears to be like a quote unquote, like smoldering myopericarditis could at any moment turn into a fulminant myocarditis, which we have had cases like that. And that, kind of in the end, it was up to the patient and like with the encouragement sort of the oncologist. But yeah, I mean, these are tough cases. Obviously, as people are more aware, labs are being checked more often, imaging is being done more often. And so they're not all fulminant cases, right? So like the textbook answer of, admit the patient, give high dose steroids, and don't ever give immunotherapy again isn't necessarily risk versus benefit wise always the best thing for the patient as far as their cancer care and overall, but you're right. I mean, in cases where it's clear clinically, for sure, like the studies have suggested that early and high dose therapy without waiting is what we should do. And that is what we do in our usual care, especially with classic cases. We don't wait for the diagnostics normally, like we did in this case.
So, just curious, you deferred the immunosuppressive therapy and then you held the immunotherapy. Was that for just a period of time, or what was the decision there?
Well, you'll see, because we're only halfway through the case.
Okay, all right, sorry.
So, Dan, it's Joe. I think what Lauren said needs to be emphasized, that this decision making is not just cardiologists and oncologists. It comes up all the time when we speak, but the patient really has to, and family has to weigh in. It's really important, and probably more important here than in most of the things that we do.
Right. Yeah. Okay.
Lauren,
Cool.
I think Avi Guha had a question.
Oh, hey, Avi.
Hey, Lauren. Hey, Jason, and hi, Jennifer. Great case so far. Did you see anything in the MRI, specifically like in the mapping part of it, which sort of suggests like smoldering versus like, I mean, is it the standard definitions, or how did you sort of differentiate between those like the subtleties on the MRI?
Yeah, I mean, another great question. Short answer is like, we don't know. We don't have enough data to know based on imaging alone. You know, this is the T2 map. It's just a small area. There wasn't like rip-roaring myocarditis here, obviously. There's a tiny area of T2. The rest was normal. So that would show something that only has like a tiny component of acute inflammation. And then we don't have T1 mapping on this case. It was done, you know, urgently on our inpatient scanner without that protocol available, although we do it with our outpatient scanner. So they're subtle findings. You'll see as we go on the case, they'll have a repeat imaging, and it's interesting to kind of see the changes. Okay,
all right,
so I think we should continue just so we have enough time.
Right.
That's okay.
All right. So in the interim, the patient had continued occasional episodes of epigastric and chest discomfort, similar in quality to those described above. Biomarkers were performed on schedule, revealing a stable trend. As for the coronary CTA, there you have it. As you can see, the mid-LAD is notable for non-calcified plaque associated with moderate to severe stenosis. Apart from this and some mild diagonal branch disease, the coronary vasculature was pretty clean. CT-FFR was then requested urgently, and I believe this resulted the same day, returning a significant result of 0.5, as you can see here, arguing strongly for hemodynamic significance of the lesion. So the patient was admitted to our main hospital for cardiac catheterization and endomyocardial biopsy the following day. Is this playing for you? Okay. Coronary angiography confirmed the presence of critical stenosis of the mid-LAD, which was treated with primary PCI and placement of a 3.0 by 18 millimeter onyx drug-eluting stent. And the lesion is even more impressive on coronary angiography than it was on our CTA. As for the endomyocardial biopsy, that revealed normal myocardium and was read as negative for inflammatory infiltrate. Please note that the patient's last dose of immunotherapy was administered about 6 weeks prior to the biopsy, and steroids were never given to this point. So the hospitalization culminated in treatment of the patient's obstructive coronary disease with dual antiplatelet therapy, initiation of a high-dose statin. Beta blockade was deferred for asymptomatic sinus bradycardia during hospitalization. Management of the patient's myopericarditis remained unchanged, with plan to withhold another dose of immunotherapy, bringing the drug treatment holiday to 2 months total, at the end of which cardiac MRI would be repeated. That data, along with continued weekly serum biomarker assessment, would inform decision-making. And so in December, the MRI was repeated, revealing interval decrease in EF from 64 to 54%, and proportion of enhancing myocardium perhaps slightly decreased. At the same time, pericardial enhancement appeared to worsen, and a new pericardial effusion was noted. So this is a side-by-side comparison of the T2 maps obtained in vertical long axis views in the first and second studies, performed about 6 weeks apart. Despite the slight difference in technique, the resolution of this marker of edema was apparent. And here we see continued mild mid-myocardial delayed enhancement involving the inferior wall, as well as impressive pericardial delayed enhancement and a new pericardial effusion. And again, all of these findings were noted at the end of a 2-month immunotherapy holiday. And that just about brings us to the present. On the oncology side, planning scans had revealed a mixed response to immunotherapy with shrinkage of the liver lesions, while the lung lesions remained unchanged. After another risk-benefit conversation with the patient, nivolumab monotherapy was resumed for 1 cycle, the third, following that 8-week hiatus we spoke of. Treatment with the entirety of the experimental protocol was resumed for the 4th cycle, administered earlier this month. On the cardio-oncology side, serum biomarker trends have remained stable since the first abnormal troponin. And we are now recommending rechecks 2 to 3 days after each treatment, as well as home event monitoring and serial echocardiography and treatment. Low-dose lisinopril has been initiated for cardio protection, and the patient is maintained on Crestor and dual antiplatelet therapy. The patient remains asymptomatic at this point. Do we have any questions about the case before we move on to Jennifer's part of the presentation?
Yeah, I think that we have a similar struggle with whether or not to do a biopsy, and I agree with doing it in this case, although I don't know if you've had any difficulty discussing with your interventionalist or whoever does your biopsies in regards to doing that after you've put a stent in.
That was a significant problem here, especially because we knew going in that the patient was going to get a PCI based on the coronary CTA with FFR. So it was done in a staged way because the patient, wasn't having like acutely rising troponins or chest pain or like true, like it didn't seem like a true ACS, right? And so patient was admitted for a few days, and over that time did get the biopsy first and then waited and then went and did the PCI after. They did like the biopsy with like a diagnostic cath and then did a staged PCI after a couple days later. Yeah, it's a good point. We have that problem sometimes.
I have a quick question. Could you just review why the coronary angiography or the CT angio was done in terms of the quality of his pain, and also because the electrocardiogram was normal and the troponin was very borderline, but there was another cause for it. So what drove you specifically to looking at the coronaries? I think it'd be just good reviewing that one sentence.
Yeah, I mean, I think there's a couple of reasons. One, I think on some level there's an obligation to, evaluate for ischemia, and ideally in a non-invasive way, especially when it's not the number one top of your differential. It wasn't, his pain, he did have some pain that was atypical, but could have been angina, although albeit atypical. And also the concern for, progressive atherosclerosis with immune checkpoint inhibitors and potentially plaque destabilization. So we tend to do, I think if the MRI was sort of ragingly obvious with a, very clear myopericarditis, we may not have gone down that road, but it was sort of subtle. And, the question of potentially if there's inflammation, whether it be smoldering or subclinical of the myocardium, similarly through similar mechanisms, through the PD-1 pathway, there could be potentially plaque destabilization as well, and sort of a, we can have vasculitis, potentially endothelial rupture. So we usually do both, but it's better to do it non-invasive rather than go right for cath.
Well, thanks.
I had a follow-up question. This is Avi again. So is there, we have seen impedance mediated biopsies for sarcoid. So is there any role in cases like these where T2 is high at a specific point to do something like that with help of EP plus the person performing biopsies? And the second question is there any role for treating with high dose steroids in this case before the cycle, given the history? Thank you.
Yeah, great questions. I mean, I think if I understood your first question, it was like, can you use the MRI to help guide the biopsy? And I think that's ideal, but usually people are only going to do an RV endomyocardial biopsy. It's pretty rare, at least at our institution, to get somebody, to have enough clinical indication to go for an LV biopsy. So we have had cases where luckily there's, LGE, the septum close to the RV side, and then, but you bring up a good point. It's patchy. And so I think most of us on this call know that the yield and the sensitivity of endomyocardial biopsy can be incredibly low in this type of scenario. We're not talking about amyloid or something where we've got diffuse disease, something where we've got patchy disease, we very often miss it. Or if it's low level like this, it might be missed as well. And what was your second question? Oh yeah, should we give steroids? Yeah, we definitely talked about, like, how about this? Why don't we just try to treat the patient and then re-challenge, as we've done with other cases, but that would have kicked this patient off of this protocol. And so that was the patient didn't want to do that. The oncologist didn't want to do that. They wanted to be conservative and monitor.
Thank you.
I think we should probably let Jennifer go ahead since we're almost at 9:30. And then, as I had mentioned before, is Jennifer Kwan. She's one of our, awesome cardio-onc fellows, also does cardiac imaging. And she's going to present some of the literature, which, has really been rapidly coming out even over the past, year, month, weeks. So
Right.
I think it's incredibly relevant to this case. And we'll try our best to keep this part to 15, 20 minutes so that we still have room for further discussion at the end. Thanks a lot,
Right.
Jennifer.
Thank you for the introduction. And actually, just a quick comment on that question about the steroids. So in the VEGF inhibitor literature, you can treat the hypertension associated with the inhibitor without changing their outcomes in terms of tumor response. But I think there is some literature that suggests that if you were to treat checkpoint inhibitor patients, that may decrease the efficacy of the checkpoint inhibitor. And based off of the mechanism, that would make sense. And I think more data is needed for that. But just to herald the use of checkpoint inhibitors and augmentation of all these novel cancer therapies, the death rate for cancer dropped significantly. I'm sure many of you guys have seen this article. So even though incidence has been kind of holding steady, the mortality associated with cancer diagnoses, particularly with big gains in the non-small cell lung cancer world. And in part, this is due to the checkpoint inhibitors that have been coming out over the years. So between 2011 and 2018, there were 6 checkpoint inhibitors approved for 14 indications. And now there's about 50 indications for use of checkpoint inhibitors. So in terms of mechanism, many people on this call are aware of this already. The tumor cells actually have kind of hijacked the normal cell function, where you have checkpoint molecules that are expressed on normal cells that tell the immune system that they are self. And the tumor cells are also overexpressing this as well to kind of keep the immune system at bay. And use of checkpoint inhibitors can lead to reactivation of the immune system to target the tumor cells. For CTLA-4, not only does it help to reactivate the immune system, but it can also activate T regulatory cells, which have an immunosuppressive effect. So for checkpoint inhibitors in the lung cancer world, that was one of the initial seminal results that showed that it can improve overall survival compared to placebo, and also improve the progression-free survival as well. In melanoma, there are more than 100,000 cases that were diagnosed in 2020. Close to 7,000 people died from it. And it was the science breakthrough of the year a couple years ago. Jimmy Carter, a former president, had metastatic melanoma, including to the brain, and he got traditional chemotherapy for 3 cycles, followed by radiation, and then checkpoint inhibitor therapy for 3 cycles. And after that, he had gone into remission, and they could not detect any metastatic melanoma in the brain. So the clinical trials that showed that the checkpoint inhibitors had a benefit for melanoma, this is one example where they used nivolumab compared to dacarbazine, and nivolumab improved overall survival as well as progression-free survival in these patients. And when they looked at combination checkpoint inhibitor therapy, nivolumab plus ipi versus the individual checkpoint inhibitors alone, there was a survival advantage by having the combination therapy. And over the years, there are more and more patients who are eligible for checkpoint inhibitor therapy. This was looking at the FDA data, and 43% of patients were deemed eligible for checkpoint inhibitor therapy. However, less than 20% benefited from the immunotherapy or responded to it. And the ones that were the highest response included the renal cell carcinoma, non-small cell lung cancer, and also melanoma. So for his work in elucidating the mechanisms of checkpoint molecules and leveraging them for cancer therapy, Jim Allison won the 2018 Nobel Prize. And given that these therapies have potential life-saving effects, this was discussed at a Yale Law School conference dedicated just to the discussion of how we can break down barriers in terms of insurance and costs so that patients can have access to these medications. And clearly the number of trials have significantly increased over the years. Between 2015 and 2017, it increased from 215 trials to more than 1,500. And in 2019, there were close to 3,000 trials looking at combination chemotherapy with immune checkpoint inhibitors. So this was the landscape of these combination therapies. And between 2017 and 2019, we see that there's an increase in radiotherapy combination as well as inhibiting the VEGF axis. We can also see here that CD40 was also included in these combination trials as well, with slight increases in combination therapy with CD40 agonism. However, there's a dark side associated with checkpoint inhibitor therapy, including in the cardiovascular realm, myocarditis, pericarditis, and vasculitis. And there is some evidence that's growing to suggest that it can also accelerate or worsen atherosclerosis. And in general, this has an additive effect. So the combination checkpoint inhibitor therapies have a higher incidence of these immune adverse related events compared to single therapy. And this was that one case report that heralded the myocarditis associated with checkpoint inhibitor therapy, a patient with melanoma with dual checkpoint inhibitor therapy who developed heart block and went into VFib and died from that episode. And the patient on autopsy had lymphocytic infiltration in the myocardium. So you see a lot of inflammatory cells. And also they were CD3 positive T cells that were there. Characterizing the immune checkpoint inhibitor presentation, this was a collection, multi-center study of 30-something cases. I'm sure everyone here has seen this, but majority of the cases occur early within the first 60 days. The most sensitive biomarker for being positive ends up being troponin, and notably less than 50% have a reduction in their EF less than 50%. There's a mortality rate up to 50% associated with checkpoint inhibitor myocarditis based off that study. And over the years, checkpoint inhibitor-mediated myocarditis has been going up as there is increased use, along with pericardial disorders or pericarditis. There is a 1+% incidence or risk associated with checkpoint inhibitors and myocarditis found in this pharmacologic VIGIBASE study. And not only can they occur by themselves, but they, as you can see from our case, they can also potentially occur together, myocarditis with pericarditis and even vasculitis. There was one other study that looked at the Danish data set between 2011 and 2017. And there were 39,000 patients with lung cancer and melanoma. About 1,000 were treated with checkpoint inhibitors. And this study found that there was an absolute risk of 1.8% pericarditis and myocarditis within a year. They also showed that even beyond 6 months, there was an increased risk of having these cardiac events, which included arrhythmia, pericarditis, myocarditis, heart failure, or cardiovascular death. And there was a 6 to close to 10% rate of having these cardiac events in the checkpoint inhibitor treated group. So we have some insights from basic science even before checkpoint inhibitors were used in cancer therapy. And this was looking at PD-L1 expression in the human heart. And you can see that there is pretty robust expression. These were way back when using northern blots to look at mRNA levels. And in a mouse model of PD-1 receptor deficient mice, these mice died earlier compared to their control counterparts. They had dilated cardiomyopathy, and they also had increased levels of autoantibodies circulating in their blood as well. So based off of some of those insights, how does checkpoint inhibitor myocarditis occur? It's most likely due to our normal cells, including the cardiomyocytes, having expression of checkpoint molecules that are saying that they are self. And by blocking that, you can also reactivate cells that are autoreactive, as well as B cells that are generating autoantibodies to normal myocardium. So diagnosis of checkpoint inhibitor myocarditis, you would get your biomarker panel and then check electrocardiogram. You can look for echo findings, including pericardial effusion, and cardiac MRI is another imaging modality that we used to help us diagnose checkpoint inhibitor mediated myocarditis. After, and you can use other modalities to rule out ischemia as well. So the cardiac MRI criteria for helping to diagnose checkpoint inhibitor myocarditis include using the Lake Louise criteria, and this would have T2 positivity, either regional or global, which would be suggestive of edema. And you can also look at T2 imaging as well. You can also have abnormal signal either regional or globally. And then supportive criteria include having LV dysfunction, whether it be regional or global, and or evidence of pericarditis, which can be evidenced by having positive T2 signaling or LGE signaling in the pericardium.
Before Jennifer, sorry to interrupt there. Just before you go on, this is Dan.
Hi.
Go back to hi. Go back to that previous, that one right there. So this, modified Lake Louise criteria. So there's at least 2 or 3 major issues that I see with this, or at least what we encounter. Is number one, so it's kind of like in the echo world, if somebody reads an EF and it's 52% and another person reads it, same images, et cetera, it's 56%, that just depends on where you put the marks and, whatever. But so there's a certain amount of subjectivity. So then in terms of the gadolinium enhancement and the pattern of it, that is absolutely a subjective thing. And then when you talk about T1 or T2, again, just like in the echo world, we constantly struggle with, if I have a patient that has an echo ordered and they go and get their echo, they may or may not measure strain. And even if they do measure it, they may or may not report on it. And even if you see a report on it, you don't know how reliable that measurement is. So in an MRI world, T1 and T2 are they're not always done. And even when they are done, there's some difficulties with quantitation. So I don't know if you care to speak on those particular issues.
Yeah, so for LGE, for sure, I think, as a trainee going through cardiac MRI, it's at least to someone who is training, it seems like the calling LGE could be subjective sometimes. Although I don't know if there's just experience and like an AI that's going on that says, yeah, this is definitely positive for LGE. In terms of T2 and T1 signal, I think the community is trying to look at different ways to make it a little bit more sensitive. Of course, you're averaging between the cardiomyocyte signal versus the myocardium signal versus like skeletal muscle, and looking at a different ratio between them. And can you make it more specific if you increase that ratio to greater than 5-fold increased versus like just greater than 2-fold increased? So I think that is an evolving area, but I do agree that there would be some differences just based off of the cutoffs that one is using.
And then how consistent do you feel different MRI locations actually measure T1 and T2 and then do it reliably?
Different MRI locations? Well, I think where you're specific, and you bring up like excellent points, Dan, and like, I think long story short, in general in the cardiac MRI field and specifically in relation to ICI-associated myocarditis, the field's moving towards more quantitative assessment rather than qualitative. And so, that was sort of the main purpose of these 2018 updated Lake Louise criteria, was adding we have T1 and T2 weighted, imaging, which can be qualitatively read, but T1 and T2 mapping adds, the quantitative, parametric mapping component, which is less subjective. And so, I think that, and, using T1 mapping pre and post to get ECV. That being said, if places people have to have the hardware and the software, updates and all of that to do that stuff. And then they also have to have their own institutional normals. So it has to be done in a kind of robust, way, in order for it to be reliable. And I think, especially like, which I think Jennifer's going to present, but like Tom's, data, the larger cohort of patients, the multi-center data, when, kind of highlights that. I think like when qualitative assessment is used for T2 and T1 in a real world setting, it's the sensitivity may not be as high. We're not going to show it today, but we have some data here, in a smaller cohort, but doing quantitative assessment, like Jennifer was talking about, doing like T2 ratios, which is also part of like Louise criteria, doing like myocardial to skeletal muscle ratio. And that we've shown has much higher sensitivity than just qualitative assessment. And so I think the field in general is moving towards that. But specifically, more study is needed in this patient population because often the findings are more subtle.
Yeah, so I think one of my questions, I probably had asked too many in the last question series, but my main question is what would be your estimate of all the MRI places, all the locations where cardiac MRI is done, that they have the capacity and wherewithal to make those measurements? Would you estimate 10%, 50%, or 90%?
So I would say, well, first of all, everybody can do the T1 and T2 assessment for Lake Louise criteria. Not everybody's going to have mapping for that additional value. I don't know the percent, especially across the world, and there's variability. Like I can tell you right now, we're in transition. This hopefully won't be long term, but our inpatient scanner right now doesn't have mapping, but our multiple outpatient scanners do. That's something we're working on. So, there's just a lot of challenges, I think, to implementation of that. But it doesn't mean that we can't still do the assessment for myocarditis with regular T1 and T2. And like the other thing we did in our study was with regular T1 delayed enhancement, we didn't T1 weighted imaging without using T1 mapping, doing percent LGE, doing some sort of quantitative assessment of late gadolinium enhancement rather than just looking and saying, setting standard deviations like we do with hypertrophic cardiomyopathy, put a reference of a normal myocardium, set yourself at whatever you want it to be. We use 6 standard deviations above normal reference to truly quantitatively assess if there's LGE there, rather than just looking at the image and saying, oh yeah, it looks like the increased signal intensity. So there are multiple, and then like strain, we can do feature tracking strain on top of regular Cine acquired, that every single site has regular Cine, functional imaging. And with post-processing, you can very easily do strain assessments similar to strain with echo, but kind of higher resolution, more points for tracking. You don't even have to have a dedicated sequence. And we also showed, similar to what Tom showed in the echo strain, that patients with the normal EF have decreased strain on feature tracking strain. So there are tools that all places can use, even if they don't have mapping techniques. But mapping, of course, is ideal, and that's kind of the way the field is moving.
Great, thank you for answering that.
Thanks, Dan.
Mm-hmm. Yeah, and so as Lauren alluded to, this was a study of 103 patients with checkpoint inhibitor myocarditis who underwent an MRI. And the one major point from the study was that it was not highly prevalent to have both positive LGE as well as T2 signaling for checkpoint inhibitor myocarditis, even amongst those where they had pathology-proven checkpoint inhibitor myocarditis. The prevalence of LGE and T2 positivity was 9% of those with EFs greater than 50%, and then 18% with those less than 50%. They also looked at the outcomes associated with different findings on the cardiac MRI, including LGE positivity, the different locations of LGE positivity, some of the volumetrics of the LV function, and then also edema. And in both their univariable and in their multivariable model, none of these parameters were predictive of having MACE when they followed them up 5 months out. And MACE included cardiovascular death, cardiogenic shock, heart arrest, or complete heart block. And 40% of these patients had developed MACE within 5 months on follow-up. So the other component in the algorithm is after you have a cardiac MRI, if it's normal, you can consider doing a biopsy through cath. And in one pathology study, they found that there were 2 major grades of checkpoint inhibitor myocarditis. Low grade, where they define it as less than 50 CD3 positive cells per high powered field versus greater than 50 per high power field. And they compared it to a patient who had a heart transplant and rejection, and noted that the pathological phenotypes were different. But as Lauren alluded to earlier about the sensitivity of endomyocardial biopsy, although this is not checkpoint inhibitor myocarditis biopsy diagnosis, this was way back in 1989, where they were looking at different myocarditis causes, including viral, including autoimmune, and also fungal infection. And in a case series of 14 biopsies or 14 patients for single specimen sensitivity, that was 20-something% for diagnosing myocarditis when they biopsied at the RV. And then if they increased the number of specimens to 3 to 4, that increased it to like 50%. And then for some where they got 8 specimens, that increased it close to 60%. In another study that was of 38 hearts that were diagnosed for lymphocytic myocarditis, it was only 17% positivity using endomyocardial biopsy at the RV. So sensitivity is highly variable and also not very high based off of these 2 small studies. Although we don't have specific literature for checkpoint inhibitor myocarditis, but given how spotty it can be, you won't necessarily see it at the RV septal region. That sensitivity may even go lower. So switching gears a little bit, in addition to checkpoint inhibitor myocarditis, we've been seeing more evidence that suggests that checkpoint inhibitors can increase atherosclerosis risk or accelerate atherosclerosis. And in this single center study at MGH, they looked at two study designs of their patients on checkpoint inhibitors. They looked at a crossover study where they looked at the patients 2 years before they got checkpoint inhibitors and 2 years after they got checkpoint inhibitors, and found that there was significant increase in risk of heart attack, need for coronary revascularization, as well as ischemic stroke after they started immune checkpoint inhibitor therapy. They also looked at patients who had cancer that had checkpoint inhibitors versus no checkpoint inhibitors, and they matched them by age, prior CV events, and cancer type. And for that particular study, they found that those who got checkpoint inhibitors had a 7-fold increased risk of having heart attack, a close to 5-fold increased risk of having stroke, and a 3-fold increased risk for needing coronary revascularization. And when they looked at the effect of statins and corticosteroids on the plaque volume, they saw that those who were on statins actually had a decrease in their plaque volume compared to those who did not have statins on board, and those who got steroids actually had also a decrease in their plaque volume compared to those who did not get steroids. And in the animal model world, use of CTLA-4 inhibitors or PD-1 inhibitors was shown to increase plaque inflammation as well as plaque progression. So this was one study of hyperlipidemic mice where they looked at the use of CTLA-4 antibody and found that in these mice that increased the percent of CD3 as well as CD4 cells, and it also increased the plaque area significantly as well. In humans, there was this one study that looked at the coronary atherosclerosis composition between patients who had checkpoint inhibitor therapy versus not, and there was no significant difference in their baseline characteristics. And they found that in the atherosclerotic plaque, for those who were on checkpoint inhibitors, they had a significant increased ratio of CD3 and CD8 positive cells compared to those who did not have checkpoint inhibitors. And this was the histology of the patients on checkpoint inhibitors. You can see increased inflammatory cells in the plaque compared to those who were not on checkpoint inhibitors. And there's just a quantification of the CD3 to CD68 ratio in the plaque. So our patient was also on a CD4 agonist, and Jason already gave a good overview in terms of some of the mechanisms that are driving why this is used as an anti-tumor agent, particularly for melanoma. So in general, the CD4 agonist can activate the innate immune system to target tumor cells, but it can also activate the adaptive immune system, so T cells and B cells, to target cancer cells. And in cardiovascular literature, activation of CD40 actually drives atherosclerosis. And in this mouse model, you can see that use of CD40 inhibition led to reduced atherosclerosis in a mouse model where the mice are prone to having atherosclerosis. So reduction in atherosclerosis in the aorta, but also in the carotids. And here is a quantification on the right side here of the aortic arch wall thickness, which is lower when they use CTL or CD40 inhibition, and also when they stained the aorta for oil red O, which stains for lipid, you can see that the lipid staining quantification was also lower in the mice that had the anti-CD40 ligand antibody. So based off of this mechanism, inhibition of CD40 can lead to abrogation of atherosclerosis, but in patients who are getting CD40 agonists, potentially this can accelerate atherosclerosis as well. So that's something to watch out for. So in screening for checkpoint inhibitor myocarditis, one thing that our patient is going to be continue to be monitored for, you would get your EKG, your BNP, troponin. Ideally, when a person is first put on it, you get those screening tools before the patient gets started on it. And then this particular algorithm that just came out in JACC Cardio-Onc, they actually get EKG and troponins before each cycle and evaluate for new symptoms, elevation in troponin, EKG changes, and if any of those are positive, there's concern if this is new myocarditis to refer to cardio-oncology and consider holding their checkpoint inhibitor therapy. And then the treatment algorithm for someone who is diagnosed with checkpoint inhibitor myocarditis, you would want to discontinue their checkpoint inhibitor therapy, start high-dose steroids. If they're stable, you can do a long steroid taper. If they are refractory to the steroids, consider adding another immunomodulatory agent like mycophenolate. And if they're still ineffective, there are other agents like CTLA-4 agonists and IVIG. Consider biopsy. If they're unstable, consider referral to advanced heart failure, and there are other agents that you can add on top of the steroids, including CTLA-4 agonists, alemtuzumab, plasmapheresis, IVIG. And so in summary, there are a growing number of cases and indications for checkpoint inhibitor therapies. We have seen significant gains in terms of improved outcomes, particularly for lung cancer, but also melanoma, renal cell carcinoma. However, there's a dark side associated with checkpoint inhibitor use, and that includes myocarditis, pericarditis, arrhythmias, conduction abnormalities, and these are all the different screening modalities to help diagnose it and further monitor checkpoint inhibitor myocarditis. And this was also from a recent review from JACC Cardio-Oncology. Checkpoint inhibitor use has growing evidence to suggest that it can accelerate atherosclerosis through plaque destabilization, increased inflammatory cell infiltration. And we also have some evidence that suggests that CD40 agonists can potentially increase the risk of atherosclerosis or destabilization of plaques as well. So thank you for your attention. Any questions?
Yeah, it's a great presentation to all of you. Thank you. We published a paper about 2 months ago in the International Journal of Cardiology that the only factor that you could, in which you would be able to predict whether a person developed evidence of myocarditis was calcification in their coronaries or in their aorta at baseline. So whether or not they were diabetic or hypertensive or got some other type of therapy or whatever, none of those were predictive. But if they had evidence of atherosclerosis that at baseline, then they were at higher risk. So that was just going along with the theme that you just presented.
Yeah, and actually in the JACC manuscript, they looked at FDG uptake, but that wasn't predictive of future myocarditis by checkpoint inhibitor.
Hey, Lauren, Jennifer.
Hello.
Jason, hi. Hey, Amit here.
Yeah,
hey, great presentation. Great presentation. Very interesting case. A couple questions, as in, now that the repeat MRI for this patient showed pericarditis, what are the plans for the patient moving forward? Is he going to get steroids, NSAIDs, colchicine, or are we just going to watch it? And are there like plans for serial cardiac MRs?
Yeah, it's a great question. I mean, I think as we kind of discussed in general, we're obviously not treating with steroids, and he's getting further immunotherapy. He has no symptoms now at all. And you kind of wonder if his quote unquote GERD from before was really angina. But, it is concerning that his pericardial disease looks worse on the MRI. And, in a different setting, we may treat that, although you could argue without symptoms and a true clinical presentation of pericarditis, I don't know, there's really data to treat that. So we're not treating him because he's clinically not presenting that way. But I think, we are going to serial MRI him, at certain intervals. And I do think that the discussion of at least, as you mentioned, colchicine, which is a great point, Whether it's really going to work in this patient population with this pathophys, I think we don't know. I think it's been shown recently in general in cancer to have benefit, but cancer patients, but not specifically in this scenario. But I think it's definitely worth a discussion. You bring up a great point. And if his cardiac MRI is worsening, I think we would consider it. Whether that's really going to prevent, you know, the concern of is with him, if he's asymptomatic, it's fine. But, you know, could he develop constriction? And we do have cases like that where they've presented primarily with a pericarditis picture. And those patients were treated actually, you know, because they clinically presented, they were treated with immunosuppressants, but kind of have developed over time worsening pericardial thickening and fibrosis as evidence on MRI. And we have one where there's concern that they might be now developing a constrictive picture. So it definitely needs to be followed, and it definitely needs to be reevaluated, whether we need to treat it from really like a prevention type, I think, of standpoint, of which, as we all know, we don't have any data for, but should be considered. It's a good point.
Yeah, and one more follow-up question. Did you guys get ECV on the repeat scan by any chance? I know the biopsy was negative, but would be interesting to see if what his ECV look like, and even in future, something to consider.
Yeah, we did not get it on that scan, but you're right. I think on previous ones we should. On next ones we should. Yeah.
Oh, it's Joe. Can I just want to ask a controversial question and sort of be the devil's advocate? Is there ever any thought that the pericardial disease was independent and had nothing to do with the checkpoint inhibitor?
Yes, meaning it could be like metastatic or something?
No, I mean just that he had, you know, there are a lot of people who have small pericardial effusions that are asymptomatic, and maybe he had some disease that isn't melanoma and isn't checkpoint inhibitor. It's just there.
Right. I think, yeah, you're absolutely right. I mean, a fair number of patients just have a small pericardial effusion or, you know, from whatever inflammation from something else. But I think of him, specific concern was that it was newly developed. It was stone cold normal. There was like no abnormal fluid. There was just borderline kind of lateral pericardial enhancement that was really subtle. And then on the repeat, there was a new small pericardial effusion that wasn't there. And there was significant pericardial thickening and delayed enhancement. So yeah, we can't say for sure, I think, obviously, that it's from the immunotherapy. But I think given the time course and the kind of clinical presentation, that's, you know, our concern. But we're just going to monitor it.
Yeah, that's a absolutely great presentation. Thank you all for really a definitive relook at what's going on with the checkpoint inhibitor myocarditis, and we appreciate everybody's attention. And I guess we'll see you same time next week. Steve, do we know what we have going on next week?
Yeah, next week, Jennifer Liu will be presenting on the use of strain in cardio-oncology, and the third Thursday of the month will be working group webinars, and we're starting on a short series on the use of different imaging modalities.
Awesome. Great. Thank you all so much. I appreciate the great presentation. Really fantastic.
Thanks so much.
Thank you all.
You guys, great presentation.
Everyone. Take care.
Bye.
Yeah, thank you. Great presentation. Thank you.
Thanks, Isaac. Bye.